On page 23 is an example of an anterior wall MI, and what probably strikes you right off the bat is that this is a tachycardic rhythm, which is kind of interesting. So if we look at the heart rate for this, let's see here. This QRS falls in a dark line, so the heart rate here is 300, 150. So heart rate of 150 right off the bat, that's quite a fast rhythm. And this is a patient in his 30s who's a cocaine user. And it's not uncommon for patients who abuse cocaine to develop severe heart disease at a very early age. But in any case, let's go through this systematically as we did with the last one. So we'll look at the leads and groupings again, looking at leads 2, 3, and AVF. And one of the other things I should mention about the 12 lead, which I neglected to mention before, is you'll notice that between the leads are these lines that divide the leads. I mention these only because from time to time these dividing lines will alter the P wave or QRS morphology, and so you may look at one of these areas where the leads divide and think that there's an ectopic beat or something, but it's just artifact. So if we look at 2, 3, and AVF, I don't see any ST elevation in lead 2. Lead 3, it's kind of difficult to say. I don't see any ST elevation in AVF, so we can rule out an inferior wall MI. Then we'll look at the anterior leads, and if we look at V1, there's just a little bit of ST elevation there, probably about 1 millimeter. V2, here's the baseline. There's a J point, definitely at least a couple of millimeters of ST elevation. V3, here's the baseline. There's a J point. V4, here's the baseline. Here is the J point. So clearly we have not just an anterior wall MI here, but we have an anterolateral wall infarct. V5, a little more difficult to say, not entirely sure, but V6, there's clearly no ST elevation, so we can rule out a lateral wall infarct. So this is a patient with an anteroseptal wall infarct.